Madam, we'll start, madam.
Yeah.
Vijayasagar, madam.
Yeah, we can start.
Good evening, Chairman Madam, Krishna Prasanthi Madam, Dr. Ayurao Garu, MBR Sharma Garu, Manoj, Alladi Mohan Garu, Siddhiveswari Madam Garu, and other senior colleagues and my young colleagues. I welcome you all to this today's educational program regarding non-diabetic hypoglycemia by Dr. Sudha Vijayasagar Madam. And hope Krishna Prasanthi Madam to address and welcome.
Good evening, everybody. Respected IV Rao sir, Chief of APAPA and mentor to all of us. Respected esteemed speaker of today's CPD program, Dr. Sudha Vijayasagar Madam. Respected Alladi Mohan sir and the man behind for today's CME and all the esteemed professors, Dr. MBR Sharma sir, Dr. KSR Swami sir, Dr. Manu sir, and particularly Dr. Siddheshwari Madam for extending great hospitality and conducting CME and being part of us, and all other esteemed delegates. Good evening, everybody. Today, it's a great privilege for all of us meeting to you on this occasion of monthly continuous professional development program for the practicing physicians. This has been conducted from December onwards, and we are happy to be having Dr. Sudha Vijayasagar Madam. No introduction to the physician community. She is a renowned physician, renowned clinician, excellent teacher par excellence, and more than that, she is a great human being, and we have seen her lecture in our APCon 22 also. Within a short notice of less than a week, Madam is kind enough to accept Dr. Mohan sir request and giving a very important topic, and this topic has been chosen even in the national APCon also. So actually today we have been requesting all the heads of the departments of medicine of all medical colleges, after creating a WhatsApp group, to keep this kind of links and to percolate this message into their respective departments to all the faculties and postgraduate students, so that those who are interested to give lectures, definitely they can volunteer themselves. We are here to give a platform to all of you. Definitely we have to share our knowledge, and we have to encourage our juniors also, so that we will be giving a platform to us. And we thank the VDO Technologies for giving the links, and we request you to kindly have all this recorded version, and so that we can keep in the website of APAPA also. I request Dr. IV Rao sir to speak few words, because even in EC meeting, we have appreciated Siddheshwari Madam, but at that time, Madam is not in the EC meeting and she was busy with conducting the academic program. I request Dr. IV Rao sir to speak few words.
Thank you, Madam Krishna Prasanthi Garu and Alladi Mohan.
Namaste, sir.
Namaste, namaste. And at the outset, I appreciate the efforts of Dr. Siddheshwari, who has conducted the regional CME program at Elore, and it was a very good success. And also, it has been a good proposition to start this continuing educational program every month. And today we are having this non-diabetic hypoglycemia, which is a very practical problem, which we all of us face when we encounter a case of hypoglycemia and the patient not seem to be a diabetic. And we know that there are various causes, maybe drugs or maybe the tumors like insulinomas, and there are several other causes probably which you may be hearing from our esteemed speaker. So without much ado, I hand over the mic to Krishna Prasanthi Madam.
Thank you very much, sir. I request Dr. Alladi Mohan sir to introduce present speaker, Dr. Sudha Vijayasagar Madam. Sir, unmute yourself, sir. Sir, unmute, sir. Alladi Mohan sir, unmute, sir.
Yes, madam. I think now I am audible.
Yes, sir. Now audible,
Yeah.
sir.
It's indeed a great pleasure and honor to introduce Dr. Professor Sudha Vijayasagar, who is currently the head of medicine at the Voluntary Health Services Hospital, Chennai. And she is She had a long innings at KMC Manipal, where she was the former professor and HOD. Madam had done her MBBS from the Stanley Medical College and her MD from the KMC Manipal. She's been the recipient of the Good Teacher Award in KMC 7 times. She has 150 plus publications, several of them focusing on diabetes. And in the RSSDI, Dr. Sudha was the recipient of Professor Srivastava Award in the Year of Grace 2013. And she has been a recipient of ICMR grant for young diabetes since 2010. And she is very much interested in the research in pre-diabetes. She's chair pre-diabetes Manipal University 2014-15. She's the principal investigator in 15 international clinical trials. And she's also one of the editors of the Journal of Diabetes in Developing Countries. Above all, she's an extraordinarily gifted and kind teacher. Most of our students, I cannot forget what Gupta spoke in the Guntur Epicon. He expressed how Madam had mentored him. Dr. Gupta is a senior physician from Pilier. With all this, we look forward to hearing our Professor Sudha Vidyasagar on a very important topic. Over to Madam.
Thank you. Thank you very much for your kind words, Dr. Mohan. And thank you, Krishna Prasanthi, and thank all of you, the organizers of this program, for giving me an opportunity to share whatever I know on this very interesting topic. Because like what Dr. Rao was telling, the slide is not moving.
Bashir, can you help us? Bashir?
1 minute.
Any person from VDO Technologies?
Stopped moving.
Slide is not moving?
No,
Can you?
Yes.
Hello.
It moved earlier.
it moved earlier. That's what I'm wondering.
Hmm.
Why it is not moving.
Ma'am,
Okay.
Once you
You can share again.
I'll share again. Okay.
Yeah.
First
To stop that share and share again.
Yeah. No, even now it's not moving.
Then you go to the slide if they are if the video are there, they should help. Else you go on to the slide mode. That should move.
Okay. That also I'm trying
Please.
to.
Ma'am, please stop sharing and close your presentation, and once again you open that.
Okay.
Kindly press the next slide, ma'am.
I am pressing it, but it's not moving. 1 minute. I'll just try to come out of this mode and then try again. Okay. Okay, I'll try this.
Click on ESC.
Okay,
Yeah.
1 minute. I'll try this.
You can go to the side panel and click the
Yes.
next slide.
Now I got it. Yeah. Okay.
Right.
Right. So as Sir Dr. Rao was telling, most of the time when a patient is hypoglycemic, the question we always ask the postgraduate or the resident on call is, oh, is he a diabetic? And then everything is easy. He's diabetic, he has missed his meal, he has taken an extra tablet, something happened to him, he did not eat. So it's very easy to solve at that level and say, if he's hypoglycemic, probably he's a diabetic who has got a problem. But if the answer from the resident comes as no, he's not a diabetic, then we are all stuck. We're all wondering what are we dealing with, because the causes of non-diabetic hypoglycemia are not simple and they are many. And then it's a challenge for the physician who is treating to come up with a good diagnosis. So I'm just going to present a dozen cases which we saw in our practice. So except 1 or 2 cases that I am presenting, most of them are my own patients. So, are all non-diabetic hypoglycemia. So I thought I would go case by case and let us see how we solve these cases. So this was a 17-year-old boy. This was about 15, 20 years ago. He came with on and off tiredness. And whenever he felt tired, he was a school going, high school boy. Whenever he felt tired, he used to eat something and then he used to feel better. At times, he used to behave badly with his classmates, and then they diagnosed that probably he has got some psychiatric problem, and then he was given carbamazepine. This was going on for some time, for almost a year, before he threw a convulsion. When he threw a convulsion, that's why the relatives, everybody got worried that he's really got a problem. And then he was taken to a nursing home where they found the sugar to be low. It was 40. So he was given dextrose and then he recovered, and clinical examination was normal. And this is the point at which he came to us. And if you look at the history that we told you, that the sugar is low, he had symptoms of something like convulsions, abnormal behavior, and tiredness, all of which was relieved by taking sugar. So we know that he is definitely satisfied the Whipple's triad for hypoglycemia. And we knew that he had hypoglycemia. There was no doubt about it. He had spontaneous hypoglycemia because it was not induced by a drug or anything like that. Now, why did he have low sugar? His mother kept on saying that she had a fight with him and he did not eat. So this was one explanation. And can a normal boy get hypoglycemia just because he didn't eat for a day? No, it cannot happen, because 24 hours the liver can manage. There's a saying that if you get shipwrecked on an island, you can survive for a week without food, maybe not water. So we know that this is not the cause. Then we did a fasting sugar. So the next step, we did a fasting sugar. It was 62 and the patient did not have those symptoms at all. So we are again stuck. He's inside the hospital, but we are unable to prove. So what did we do next? We did a prolonged fast. So we did a long 72-hour fast. When we did that, then we hit upon the low sugar. There was a low sugar, he had symptoms, and then we knew that we have proven hypoglycemia in him. So the next thought comes, okay, there's a fasting hypoglycemia on a prolonged fast. Is it an insulinoma? So the next step was we did the fasting insulin and the fasting sugar simultaneously. Again, we were in for a surprise. We were expecting to see a high insulin, but we got a normal insulin. Sugar was low, but the insulin was normal. It was not high as we would expect in an insulinoma. But look at the case carefully. This is one of the very important lessons that we learned. The fasting insulin is actually disproportionately high, very high compared to the level of sugar. At this level of sugar, we shouldn't be seeing any insulin at all. So normal insulin is not normal. It is disproportionately high in this scenario. Luckily for us, when we did the C-peptide, we got slightly high. So we thought, okay, now we know the source of hypoglycemia. It's coming from the pancreas. It's probably an insulinoma. So if you look at the criteria for the insulinoma, the sugar being low, relief of symptoms after eating, an increased plasma insulin, and an increased C-peptide, an increased proinsulin, and the absence of sulfonylurea. But like I told you, the increase that we see here should be proportionate to the sugar. If the sugar is low, we should not see that insulin at all. Even a normal insulin at that sugar is a high insulin. So then we know that we are chasing an insulinoma. So we wanted to see where is this tumor, because the surgeon has to operate. So we did an ultrasound, normal. We did a CT scan, normal. We did an MRI, still normal. So again, we are stuck. We are wondering what is it and why is not coming out on any imaging. The next step would have been a somatostatin scintigraphy, which we were not doing there. But one thing we did was we convinced the surgeon to open and see whether there's an insulinoma. This happened only because the surgeon happened to be my friend for 20 years. So on a corridor, I still remember him asking, "Are you sure, madam? Because your insulin is normal. Are you telling me you're still having an insulinoma?" I thought for a long time, but then I said, probably yes, because the way it is, I cannot think of anything else. Open him. So we took a chance. We opened up this patient, and intraoperatively, ultrasound was done. And the surgeon actually told me he felt the pancreas. He felt the pancreas inch by inch. And then he found there's a small tumor, 1 centimeter in the tail of the pancreas. Once he felt this thing, he resected it. Patient actually recovered fully after this and came for a follow-up after 2 years, entirely normal. So this case taught us many things. What I told you is in a patient where the imaging did not pick up, but the imaging can pick up. As we can see here, we can see on the CT or the MRI an insulinoma. It's not that every time it will be not visible. It can be visible. And these are the investigations that we do. And of course, nowadays we have the endoscopic ultrasonography. So through that also, we can image the pancreatic tumors. So we do have very good imaging facilities now. How common is an insulinoma? It's 1 in 4 people in 1 million. So it's obviously a very rare diagnosis. There's any age it can come, but there's a 90% rule which says insulinomas are benign, they are solitary, they can most often are intrapancreatic, and most often they are small. This is the problem with them because many of them are just less than 2 centimeters. And like we said, sometimes the imaging can miss. The lessons learned in this case were that a normal fasting insulin does not rule out an insulinoma. It's the proportion between the fasting insulin, the fasting sugar that is important. And again, imaging can be doubtful. If you're convinced, then an intraoperative ultrasound is probably the best way of picking up an insulinoma, and the surgeon can probably resect. So these are 2 important lessons that we learned from this case, which I can't forget at all because it was so interesting at that time. Now let's go on to another common case. Staff nurse comes with hypoglycemia. She has a troubled marriage, suspected to have consumed an overdose of glibenclamide her mother-in-law takes. This is again from our own hospital. We've got a patient like this. She denies taking it. Obviously, no staff nurse is going to tell you that I've taken glibenclamide and I've come here. She's not going to tell you that. Now, which investigation will prove the diagnosis? This was put up for the postgraduates. What will she have? Will she have a low C-peptide, low fasting insulin, high C-peptide, high insulin, and some other combinations that I've given? But the answer to this is because sulfonylurea as a secretagogue goes through the pancreas. So obviously we'll have a high C-peptide and a high insulin. That is the right answer. Why we put this up is because remember the only way to differentiate between insulinoma and insulin secretagogues induced hypoglycemia, that is for example a sulfonylurea, is by detecting the drug in the blood or urine. There's no other way we can differentiate. So it's very important to remember that a sulfonylurea induced hypoglycemia will look exactly like an insulinoma. The context is obviously different. Of course, the management, just I wanted to put up one word. We can give glucose, we can give glucagon, hydrocortisone. Remember, sulfonylurea has a prolonged action, especially something like glibenclamide will act for 24 hours. So we may have to continue the drip for 24 hours. If you go and stop it in the middle, the patient like go back into hypoglycemia. And of course, octreotide is one of the drugs that would help in a management of sulfonylurea-induced hypoglycemia. Now, I just put this graph up, though it looks a little complicated, for one simple reason. I just want you to look at the third part. We'll come to the others later. When you give exogenous insulin, like I told about a nurse taking sulfonylurea, there can be patients who are injecting insulin into themselves and coming with a hypoglycemia for whatever reason. If that happens, now if you look at the 5 things that are put there, what we find is this exogenous insulin when you give, the insulin levels are high and the C-peptide is low. This is called the insulin C-peptide disconnect. Everywhere else, if you see an insulinoma, insulin is high, C-peptide is high. Sulfonylurea, insulin is high, C-peptide is high. Non-insulin mediated, insulin is low, C-peptide is low. But if you get a difference between the two, a disconnect between the two, where you get a high insulin but a suppressed C-peptide, the diagnosis is exogenous insulin administration. And that's why we do the insulin. We also do the C-peptide just to see whether they're going the right direction or not. If they are going opposite direction, the diagnosis is insulin-induced, exogenous insulin-induced hypoglycemia. Now let's go on to another case. A 48-year-old non-diabetic man has had repeated episodes of severe hypoglycemia for the past 4 months. It occurs 3 to 4 hours after meals. He gets dizziness, palpitation, tremors, diaphoresis, everything suggestive of hypoglycemia. Eats a carbohydrate meal, gets all right. During these episodes, blood sugar plummets to 30 to 40. No history of fasting hypoglycemia, no exposure to insulin or sulfonylurea. Now, what is the diagnosis? So, it's a completely normal man. Repeated episodes of postprandial hypoglycemia he is getting. Now, this is a disease that again, recently one of my postgraduates from Manipal presented it in the national conference, which is called autoimmune insulin hypoglycemia or Hirata disease. Now, this is an autoimmune syndrome where you get increased insulin causing hypoglycemia. This is because of insulin autoantibody which is present there. And these people do not have an insulinoma, they don't have a exogenous insulin, etc. Now, why does this occur? That is because these insulin antibodies, these are binding to the endogenous insulin, and from these antibodies, the insulin is released continuously after that. So after everything is over, the insulin keeps on coming out of the antibodies, and that causes the hypoglycemia, and that happens 3 to 4 hours after a meal. So Hirata's disease is a rare disease, more common in Japanese. The person who described is Hirata. That's why it's named after him. So there are case reports from India. I have put up 3 case reports that I came across where they have diagnosed autoimmune insulin disease causing hypoglycemia. Now, if you look at the difference between an autoimmune insulin syndrome and an insulinoma, the first major difference is that the autoimmune insulin syndrome is postprandial. Remember, our man had 3 to 4 hours after eating only, he got hypoglycemia. Whereas insulinomas, traditionally fasting, can occur postprandial also. And look at the autoimmunity manifesting itself in multiple ways. So you have a Graves' disease, rheumatoid, SLE, all these other conditions are associated with the Hirata disease. And of course, there are many drugs which can trigger this autoimmunity and cause an insulin autoimmune syndrome, like methimazole, carbimazole, which we use for thyrotoxicosis, and even proton pump inhibitors have been known to cause. So a drug exposure and autoimmunity is very, very important in the diagnosis of an insulin autoimmune syndrome. If you look at the insulin levels, they are markedly elevated, fantastically elevated, whereas in insulinoma, they are moderately elevated. This I will explain a little later, what is this insulin C-peptide ratio. And of course, an insulinoma will have the imaging showing an insulinoma. So the main difference between these two is this is postprandial, this is fasting, this has got other autoimmunities, and it's got exposure to drugs. That is what makes it an autoimmune syndrome. So like we said, it can be recurrent. What is very important is if you withdraw the drug trigger, suppose you identify that is a carbimazole that is causing the autoimmune syndrome. If you remove that, the patient will be completely cured. So that's why it's important to remember this in a non-diabetic. Look at the drug chart. Some drug may be an offender. If you withdraw it, patient may become all right. And the treatment for an autoimmune insulin syndrome is actually small frequent meals, because you don't want him to go postprandially into hypoglycemia, don't want to stimulate a lot of insulin. And of course, a carbose can be given. For the immunosuppression, because we know it's autoimmunity, you see the whole list of immunosuppressive corticosteroids, plasmapheresis, rituximab, and everything else can be done. Okay. So this is an autoimmune syndrome, Hirata's disease, but not only present in Japan. Like I said, it has been described in India also. Now, we mentioned a word about the insulin C-peptide ratio. The normal insulin bar C-peptide ratio is less than 1. That's because of a very simple reason. The insulin half-life is only 5 minutes. The C-peptide has a much longer half-life. So whatever C-peptide you produce is going to live long, right? So your insulin C-peptide ratio, though it is equimolar, you get 1 insulin, 1 C-peptide, isn't it? After all, it's coming out of the C-peptide only. It should be equal. But because of the difference in half-lives, you get normal person less than 1. But if you have a tremendously increased insulin, there are only 2 conditions where you get a more than 1 insulin C-peptide ratio, that is autoimmune hypoglycemia and exogenous insulin. So that is why, again, the insulin C-peptide, both to be done, can give a clue regarding the etiology of the hypoglycemia. Like we said, only in these 2 conditions, it is more than 1 because of the enormous amount of insulin that comes out. Right. Let's go on to another case. Again, one of our patients, non-diabetic man, fever for 3 days. He was given treatment. He came with a hypoglycemia, came with drowsiness, 38 sugar. He's not a diabetic. Now, when we look at the drug chart, what are we looking for in this? Commonly quinine, those days we used to use a lot of quinine for malaria. So then we used to get, and of course the quinolones can cause hypoglycemia. We have seen patients coming with quinolone induced hypoglycemia, but there is a lot of drugs otherwise. Apart from the usual insulin, sulfonylureas, quinolones, sulfonamides can cause hypoglycemia, oxychloroquine can cause, salicylates can cause, beta blockers, pentamidine, lithium, all these drugs can cause. So whenever you see a non-diabetic patient with hypoglycemia, check the prescription. What is it taken in the recent past which can cause hypoglycemia? The alcohol I will describe a little later. Let's go on to another case. This is not my patient. This is taken from somebody whom I know, who managed the patient like that. She's a nurse who has got a very high BMI, underwent a laparoscopic Roux-en-Y bypass, and then she was fine for about 9 years. She was fine. Then she started coming with repeated episodes of hypoglycemia, and she lost a lot of weight. 5 years after the surgery, she's getting more and more hypoglycemia. This is happening within 1 to 2 hours after eating and is relieved by taking simple carbohydrates. What is the diagnosis? Post-bariatric surgery, postprandial hypoglycemia is very well known because of various causes. If you look at the mechanisms of the Roux-en-Y causing hypoglycemia, there are many. I will not go into the detail, but one of the most important thing is very fast absorption of carbohydrate and dumping into the intestine, which is causing a hypoglycemia because of increased trigger, and also supraphysiological levels of glucagon like peptide and other incretins have been implicated. So there are many mechanisms, but post-bariatric surgery hypoglycemia is an important phenomenon. And again, that should be tackled by small meals, etc., etc. This is again one of my patients. He was a 40-year-old man. He had a gastric ulcer. Years ago, he was operated with a gastrojejunostomy. Post-surgery, he feels weak, tired, sweating, giddiness. He used to go into syncope. His mother used to come and tell me he's falling off after eating, especially after eating an ice cream. It's a very typical history that whenever he took an ice cream, 3 hours after that, he would just fall. He would just lie down and he would be zonked out. Now, the blood sugar at that level was 45. Now, what is this? This is late dumping. Similar to the postprandial, this post-bariatric surgery, because you cut off the stomach, again, you have a fast emptying of the carbohydrate, releasing a lot of insulin, causing a hypoglycemia. So actually, this man who used to come with us, we put him on acarbose and he did better after that. And also we used to ask him to eat small meals like that. Okay, and things that delay gastric emptying like domperidone can be given. Of course, we did not use octreotide in him. But this is again an important phenomena to recognize and treat. And the differentiate the autoimmune syndrome and the late dumping. Remember, both are postprandial. Okay, of course, there is history of gastric surgery only in this thing. The timing is the same. The hyperinsulinemia is the same. The offending drug is present in an IAS, not present in post-dumping. High carbohydrate consumption causes more hypoglycemia. Look at the vasomotor symptom, like my patient who used to just fall off the bed, fall off wherever he's standing. Once he fell down in a bus stand. That's when the mother brought him. Now this happens, the vasomotor symptoms are a feature of the late dumping that is present. Of course, these are autoimmune antibodies are present in this. But remember, two causes of postprandial hypoglycemia are the autoimmune insulin syndrome and the late dumping. There's also another variety called idiopathic postprandial hypoglycemia. A very vague entity came 3 times in the literature, but it is there 2 to 5 hours after eating because of the low initial phase of insulin and a rebound later. Some patients go into a hypoglycemia much later after eating, and this may be a marker of prediabetes. So it's an ill-defined entity, but it's one of the causes of postprandial hypoglycemia. Now, some common causes that we all know, let's just run through. So cirrhosis, we all know. 40-year-old cirrhosis, develop infection, goes into hepatic encephalopathy. We know that hypoglycemia in a cirrhotic patient is always a bad prognosis. That means the liver is probably empty. There's nothing in the liver, no glycogen there. That's why that is happening. This is because of low glycogen stores, decreased insulin uptake by the liver, and the presence of infection. All of them, sepsis, all of them cause hypoglycemia. It's a bad thing to have in a cirrhotic patient. Also, we have a 40-year-old man with acute viral hepatitis and altered sensorium. Liver enzymes are low, lipid and hypoglycemia. What is his prognosis? Very bad. So if you have an acute liver cell failure, you got a hypoglycemia, that's a very poor prognosis. That again shows you that the liver is very, very damaged. So this again is an important cause of non-diabetic hypoglycemia. In the ICU, this is again patients whom we see day in and day out. Even in Chennai, I keep seeing patients like this. So necrotizing fasciitis, septic shock, AKI, everything is there. And the staff nurse notices that the patient is drowsy. And remember, many of these patients in the ICU are unconscious or semi-conscious, and they cannot even complain that they're wanting to eat or anything. And then you find the patient not looking good. Always do a sugar. To do the sugar is 30. So I remember we almost lost a patient who was lying there in one corner, just looking a little quiet. If a patient looks very quiet in the ICU, we have to think maybe he's in hypoglycemia. He can't tell you. This is because of a combination of many things. We have a liver cell failure. We can have a renal failure. Renal failure is a very important cause of hypoglycemia in the diabetic and in the non-diabetic. Remember, we always teach our postgraduates, if you have a diabetic patient who's suddenly going into hypoglycemia on the same amount of insulin or whatever you're giving him, check the creatinine. Because if the creatinine is high, then whatever insulin or whatever drug you're giving is not getting excreted. And remember, the neoglucogenesis, 25% of the neoglucogenesis is coming from the kidney. So if there's a kidney failure, you're losing out on 25% of neoglucogenesis. So remember, a renal failure in any context can cause hypoglycemia just by itself, and in the context of a sepsis, in the context of diabetes, all of them. So in a patient in the ICU with hypoglycemia, everything is contributing. So he's got liver failure, he's got renal failure, that is causing decreased insulin clearance, and of course sepsis by itself without anything can cause hypoglycemia because of cytokines causing increased peripheral utilization of glucose. So in the ICU, hypoglycemia is very dangerous in a non-diabetic. So underdiagnosed, especially sedated patient on the ventilator, comatose patient, he can't tell you what's going wrong. So that's why the nice sugar study, which came out with the recommendations that in the ICU, please keep the sugar not between 110 and 140, but between 140 and 180. They relax the sugar levels because hypo in these patients is much more dangerous than hyper for a short period. So again, hypoglycemia is associated with a lot of mortality in septic patients. Now, let's look at another page. This is a very simple case. So fever, weight loss, giddiness, vomiting, and then this patient has wasting, BP is low, and the electrolytes are a giveaway. You got a hyponatremia and a hyperkalemia and a low sugar. The diagnosis is very obvious. This is an Addison's. So again, we had a patient like this who was coming with weakness, tiredness, and all that, and a low BP, and this hyponatremia and hyperkalemia and hypoglycemia. This combination of biochemistry is very classical. Of course, I didn't write he was pigmented because that would be a total giveaway. That's why I kept it a little like that. So Addison's disease is an important cause of hypoglycemia. So looking at not only Addison's, there are so many causes: Addison's disease, hypopituitarism, hypothyroidism, and all the failures. I talked about renal failure, but even cardiac failure can cause bad hypoglycemia. So the presence of an endocrine disease or a cardiac problem or a major organ dysfunction can cause hypoglycemia. There's some disturbance going on.
Can everyone mute, please? Can everyone mute, please?
I think the person there can actually mute. The technology person can mute.
Bashir, can you help us? Bashir, can you help us? Kindly mute except the speaker.
I think one person's phone is making so much noise.
If it is Amanchi Sirisha, Dr. Garu, can you please mute yourself? Amanchi Sirisha.
Okay, I think we got it right. Okay. So the next case is again an interesting case. 45-year-old non-diabetic patient went on a drinking spree one night because he got a raise in the office. He got a lot of money, and so he drank a lot. For the past 1 week, he was working on a project and he was irregular in his meals. He was not eating properly. He was on this project and he was consuming alcohol even otherwise, and he became malnourished. One morning, that is the next morning after he got his raise and drank himself to glory, he was found unconscious with a blood sugar of 38. What is the mechanism of this? This is obviously alcohol-induced hypoglycemia, but let's look at the context. Why alcohol causes hypoglycemia? It increases insulin secretion but doesn't give you the calories. It does not prevent glycogenolysis. So immediately one doesn't get hypoglycemia. When is this man getting his hypoglycemia? He's getting it next morning because he is drunk, he has slept, and then can't get up at all. Prevents neoglucogenesis. So that's why there's a late onset hypoglycemia in this alcoholic patient, and it may blunt the counter-regulatory response. That's why he's unconscious. Otherwise, he would have got palpitations, sweating, he would have gone and eaten something. It doesn't give him the chance. So because the alcohol blunts the counter-regulatory response. So what do we tell a person who's got alcoholic hypoglycemia? No long fast. Don't fast very long and follow it up with the drinking, because you will go into hypoglycemia, not now, but 12 hours later. So that's what happens in an alcohol-induced hypoglycemia. That's why I put up this clinical scenario. Let's go on to the next one. Again, a very, very interesting case. I have seen only 2 cases like this in my lifetime. It's a very interesting case. So a 65-year-old man presents with weight loss, loss of appetite of few months duration, comes with persistent hypoglycemia. This man was just always 30, 40, 30, 40. Every time his dextrose drip. Lactate levels were very high. Okay. And the BP was normal. So obviously it's not type A lactic acidosis. It's obviously type C, B or whatever. Okay. So it's not type A. He's not in shock, but he's getting hyper lactate levels and hypoglycemia. What's the diagnosis? This is called Warburg's effect. It's a type B lactic acidosis in malignancy. The Warburg effect was described by Warburg, Otto Warburg, who got the Nobel Prize for this. Now, what happens is, even in the presence of oxygen, the cancer cells demonstrate an anaerobic glycolysis, and so they convert glucose to lactose because of a fermentation through the glycolytic pathway. And so that is why you get a high level of lactate and you get a hypoglycemia. And this is what you are using in the PET scan. The glucose hunger of the tumor is what you are using in the PET scan to identify where is the tumor. So Warburg effect can cause, this patient whom I saw was a case of non-Hodgkin lymphoma, and he became sick and we could not save him, but he had such a high lactate level and always in hypoglycemia. So this is an important cause of non-diabetic hypoglycemia. So this combination of hypoglycemia and hyperlactatemia is found very few conditions, like paracetamol-induced acute liver failure. We know that liver failure can cause high lactate, severe malaria also, lymphomas, and glucose phosphate deficiency. So we get this combination. There are very few causes of that, like we said, and that should be thought of. Malignancy-induced Warburg effect. And one of the strange things about the Warburg effect is that even if the patient is very low sugar, even the patient whom I described had very low sugar, was fully talking, was nicely talking at 30. So it was very strange for us that 30 milligrams of sugar, somebody talks. This is because the lactic acidosis somehow prevents the loss of consciousness. And this is a phenomenon that has been described, that they are not in coma when they have a high level of lactate. Okay. Again, one of our patients, not his X-ray, of course, a 70-year-old non-diabetic man came with breathlessness of 3 months duration, feels weak and tired. In the ER, his sugar is 45. That is his chest X-ray. Now, the chest X-ray is a big giveaway. We all know, we can see that there is a mediastinal widening. So that is a non-islet cell hypoglycemia. Non-islet cell hypoglycemia has been described in many, many tumors. Though I put up a mediastinal widening and a lymphoma there, actually the commonest cause is a hepatocellular carcinoma. So hepatocellular carcinoma, fibrosarcoma, mesothelioma, adrenocortical carcinoma, stomach carcinoma, pancreatic, so many causes, lymphoma, all of them are cause of non-islet cell hypoglycemia because of the production of insulin-like growth factor. We call the big IGF, insulin-like growth factor 1 and 2, which are produced by these tumors, which act like insulin and cause hypoglycemia. So hypoglycemia in a non-diabetic, if you're suspecting a malignancy, always do the IGF levels. The IGF 1 and 2 levels will give the diagnosis. Now, this is again a simple case which I cannot forget because we were all surprised by this case. The lab calls you up and warns you that 30-year-old patient has a blood sugar of 35. He's sitting in front of you, fully conscious, well-oriented. All he has come for is a fever of 3 days duration, but he is fine. What are your possibilities? It is artifactual. It's a lab error of a hypoglycemia. Now, when does this occur? If you put the glucose, it's not transported to the lab early enough, that all the cells in the blood will eat up the glucose. So this will especially happen when you have a leukemia, hemolytic anemia, or polycythemia. Actually, the patient whom I saw had a polycythemia. And because of polycythemia, even without the late transport, his sugar came as 35 and he was perfectly all right. So we knew that is artifactual. So all you have to do is to transport it fast and then account for this before we call him as hypoglycemia, because he is not hypoglycemia, it's a lab error. One of the things that came out this is from the Lancet, which talked about this Muzaffarpur cases in 2014, where many people were diagnosed of something like a Japanese encephalitis. All children were called as Japanese encephalitis and they were dying and all that. But ultimately, it proved out to be because of the consumption of the lychee fruit. The lychee fruit grows in summer, and these children from poor communities, they have nothing much to eat and they are hungry. They don't have anything to eat on an empty stomach. They go and take up the lychee fruits and eat. And that can cause hypoglycemia, and that can present like an encephalopathy, which is what was described in this Lancet publication. Now, I think I finished all the cases. Just a word about the treatment. I don't think this is very important also. But anyway, we know that we should give a conscious patient, ask him to take something. If he's unconscious or semi-conscious, give the dextrose. You can give a glucagon and always give him something that's easy to swallow. And in a sulfonylurea induced hypoglycemia, give an octreotide is what we say. But remember, once you document hypoglycemia, give the dextrose. As always, document sugar after 15 to 20 minutes and then take it from there, because the cause of hypoglycemia may act prolonged. Suppose you have been on a long-acting insulin or an intermediate-acting insulin, just giving just the 50% dextrose or 25% dextrose will not stop. For the next 8 to 12 hours, the action of the insulin or the sulfonylurea will go on. So account for that. So immediately you must do after 15 to 20 minutes and keep doing till the patient is able to protect himself from hypoglycemia. Patient, this thing is important. So let's just run through what we talked about. We talked about an insulinoma in a 17-year-old boy in whom we diagnosed only on table. We talked about a Hirata's disease, which is an autoimmune insulinoma, insulin hypoglycemia, which is postprandial associated with autoimmunity. We talked about sulfonylurea and insulin, which is factitious. Gastric surgery dumping, which causes hypoglycemia later on. Drugs and alcohol we mentioned. Then we talked about sepsis and major organ dysfunction. We talked about the Addison's and the hypopituitarism and the hypothyroidism. We talked about the Warburg effect, which is part of a malignancy. And then we concluded with a non-isolated tumor, and finally an artifactual hypoglycemia. I think with that, we finish the spread of cases of non-diabetic hypoglycemia. Most of it are from our own case that we have seen. I hope this has been useful to you. Thank you very much for the opportunity.
Thank you, madam. Thank you very much.
Madam.
Excellent, ma'am. Excellent.
Excellent coverage in the form of case presentations. There is a quite interesting and eye-opening to the majority of the youngcomers or even senior professional colleagues. There is a nice presentation, madam.
Thank you. Thank you.
You can take up questions, ma'am.
One slide before. Yeah. Good. Thank you.
Sir, can we take up the questions, sir?
Yes,
Questions
madam.
and comments.
Yes, madam.
Sir, Dr. Ivy Rao, sir, Dr. Ramnamurthy, sir, Dr. MBR Sharma, sir.
Respected API members, any of the postgraduates who joined can interact with the speaker, can put 1 or 2 questions.
Or you can put in the chat box also. Sir,
It was a
Ramnamurthy, sir, unmute, sir. Sir, Ivy Rao, sir, Matadan, sir.
Yes, yes, it was a very excellent presentation, ma'am. Just I would like to clarify a few points. What is the level at which you call it as a hypoglycemia, blood sugar levels? What is
Yeah.
the cutoff?
Right. Sir, the cutoff is actually been varying all the time. The ADA now doesn't say a cutoff at all. Generally,
Oh.
it's accepted around 55, but the ADA defines it as severe hypoglycemia as somebody needing another person's help to recover from the hypoglycemia. So it's never actually a level. Less than 70 is always dangerous for a diabetic or otherwise. Less than 55 is what we say, but many books say 50 also. So the
Okay.
level is never a number, sir.
Madam, something about idiopathic postprandial hypoglycemia.
Yes, sir.
What can you explain a little more why it occurs, ma'am?
Sir, actually, the cause of the idiopathic postprandial hypoglycemia is not known. They say it is because of the early insulin has two phases. The early phase, which is coming out from the pancreas from the pre-prepared insulin granules which are present, which come immediately, and the late phase, which comes after the pancreas begins to prepare more insulin and sends it out. So we all know that even in type 2 DM, the early phase of insulin is the first thing to be affected, and then the late phase is affected later. And that is why sometimes you can get, hyperglycemia initially and a hypo later, even in a type 2 DM. So idiopathic postprandial hypoglycemia happens because you don't get the early phase of insulin. So there's a problem with the release of the early phase of insulin, and the late phase works. So actually the food has finished its work and the food is digested and gone. After that, the insulin comes out of the pancreas and maybe hits you 2 to 5 hours later. This is the explanation that is given, sir.
Thank you, madam. Thank you.
Hey, Dr. Ramanamurthy.
Yes, sir.
Hi, good evening, Ramanamurthy garu.
For children and infants, hypoglycemia levels less than 45.
Yes, yes,
That is the only thing I just want to offer.
yes, correct,
For
sir.
adults, of course,
Yeah.
about 50 like that.
Yes,
But children and infants, less than 45.
yes.
And a very nice presentation, madam.
Thank
You
you, sir.
deserve commendations.
Hello. Good evening, madam. My name is Dr. Malli Dorasanamma. I'm a physician.
Yes,
Madam, I have seen two patients who were using clopidogrel for transient ischemic attacks.
okay,
They came with repeated attacks of hypoglycemia.
okay,
When I did the insulin levels was high, but I did not do the C-peptide levels, ma'am.
right.
I have seen literature saying that clopidogrel can cause hypoglycemia. So I stopped the clopidogrel and started him an aspirin.
Yes.
All the hypoglycemic attacks went off.
Oh, very good. Yeah,
And his insulin levels also came normal, ma'am.
okay, okay. You should publish. I mean, literature is enriched only by cases like what you're describing, because
Yes,
there are
ma'am.
many drugs which can cause, like I told you, even beta blockers, salicylates, so many things have been implicated. So clopidogrel, I have not seen a clopidogrel induced hypoglycemia, and I'm learning
Okay.
from you as you speak to me.
Thank you very
But one thing I always remember is that if you have an unexplained hypoglycemia, always look at your drug list. Always look at your
Yes,
drug
ma'am.
list and then
Yes,
read
ma'am.
your literature like what you did. I think you did a brilliant job of finding out the cause, and then you treated the patient well. So I'm not experienced this clopidogrel induced hypoglycemia, but
Okay.
it's very possible, like what you say, that if you removed and the patient became all right, you may be completely right. But my
Yes.
advice to you, publish.
Sure, ma'am. Thank you very much, ma'am.
Right, right.
Thank
Nice
you.
presentation, ma'am.
Yeah.
Yeah.
Madam, I'll add to that. Recently, in I think in Tirupati also, one of the renowned doctor had the same
One
problem.
renowned diabetes doctor.
Yeah, the same thing after extraordinary, excellent battery of investigations in corporate hospitals in discussion with Dr. Nihal Thomas sir and CMC Velu, it
Yeah.
has found out to be the clopidogrel induced the
Okay.
non-diabetic hypoglycemia, sir.
Okay, right.
So we have been used to this kind. It has been there for past 6 months.
Right.
The discussion is going on in the doctor's group, clopidogrel induced hypoglycemia.
Right. Because
Yes,
salicylates are mentioned, But clopidogrel, I didn't really see. Salicylates are mentioned. Yes.
Madam, I have one small observation. Do you remember
Yeah.
that cotrimoxazole tablet
Yes.
during preparation, it was the basic drug was dumped
Sulfadral.
dinyl.
Yeah.
Do you remember, madam, that
Yes.
that happened in Karnataka
Yes.
in a cataract camp?
Yes. Correct.
Madam,
Yeah.
what is the precautions you suggest?
I don't know, sir. Because actually speaking, the cotrimoxazole and the dianyl look very different. Size
But the
wise
basic
and
drug went to cotrimoxazole manufacturing
like that,
unit.
manufacturing unit. Okay. We can't do anything, sir.
You
But
remember, madam, that?
moiety wise, they are very similar. Moiety wise, the sulfonylurea, the cotrimoxazole, they are similar. And I have seen one patient who got hypoglycemia after taking cotrimoxazole. There are many explanations for that. One of them is the albumin binding of the sulfonylurea is displaced by this cotrimoxazole. Like that also they say, sir. But right at the factory level, I don't know what can you do. I'm not sure.
Yes, excuse me if I can add a point. I am YVS Prabhakar calling.
Yes.
Actually,
Yes,
the sulfonylureas were discovered as a kind of accident
Yes.
when they were trying to discover better sulfonamides during the Second World War time.
Correct.
So they were trying to synthesize more sulfonamides because at
Yes.
that time there were no antibacterial agents that were available.
Right.
So at that time, all those animals, experimental animals, were dying of hypoglycemia. So that's when the concept of this treatment of diabetes through sulfonylureas has come up.
Yes.
So it was a basic research for sulfonamides, which has resulted as a byproduct of sulfonylurea. So I think that's why probably some of these
Yeah.
patients who are taking maybe
Yes.
one of those sulfonamides like
Yes.
cotrimoxazole are
Yes.
getting hypoglycemia.
Correct. Possible.
Thank you, sir. Thanks for your
Yeah.
nice comments.
Yes.
Thank you, sir.
Respected ma'am, this is Dr. Teja. Can I ask a doubt?
Yeah, sure.
Yes, please.
Yes, ma'am. Yes, ma'am. Yeah. First of all, thank you very much for this excellent and enlightening session, ma'am. Yeah. So coming to the question, I have seen like old age fragile ICU case, 2 cases where they become suddenly unresponsive and the
Yeah.
blood sugars were around 120, 160. But still, after investigating the basic electrolytes, fluid management and etc., I didn't had a clue. Then I had given dextrose to take a chance, and they have surprisingly recovered. So my question is like, what level of sugar should we consider as hypoglycemia? My experience was like around 120 to 160 also. Patients presented with symptoms of hypoglycemia and they have recovered after giving dextrose. Can you
Okay.
add a note on this? Thank you very much.
Yeah. Like I answered previously, the level at which hypoglycemia is declared is now, the ADA specifically says that there is no level. Okay. Somewhere around 55 is what they say, but there is no cutoff level at which you can call it hypoglycemia. There's nothing like that. The reaction to hypoglycemia, the hypoglycemic symptoms as such, for example, in a diabetic, if you take, suppose you're treating a diabetic patient and he has a 400 sugar, and then you bring it down to 250. At 250, this diabetic patient will have all the symptoms of hypoglycemia. That is because of the set point change. The change in the set point, the autonomic nervous system thinks that 250 is hypoglycemia because it's used to 400. That is the
Yes.
explanation given for that. But what you are describing is something else. You are telling that at 120 or 160, the patient is losing consciousness. Now, usually neuroglycopenia occurs less than somewhere around 30s, 30, 35. At that level, only patient become neuroglycopenic and become, drowsy. 120
Yes.
to 160 becoming neuroglycopenic, I have not seen. I have not seen patients like that. But if they are, getting drowsy at 120 or 160, I don't know whether the glucose is being utilized in the brain, not utilized in the brain at 120 to 160. I'm not sure of that. But the symptoms of hypoglycemia depend upon the set point, but that is for the autonomic nervous system. But I'm not sure I've ever encountered a neuroglycopenia at 120 or 160. If anybody
Yes.
else knows, you can please answer. So I'm
Yes,
not
ma'am.
aware
Ma'am,
of this.
yeah. Another thing is I have checked for capillary glucose, the glucose stick thing.
Yeah.
So is there a gross difference between glucose stick and like the actual venous glucose?
Okay. There is. Because sometimes the capillary glucose is completely unreliable in the presence of shock. The presence of
Yes.
shock. So that's why we don't do from the finger, we do from the earlobe. You want to do a capillary glucose, or you take the arterial blood. You take the arterial blood and send it from an arterial line. That's what we do. So there will be a difference, but the capillary glucose will be slightly lower for this whole blood. But whether it could be just a measurement problem, you can always check with the plasma glucose in the lab. That's probably one of the first things that you should do. But the way you're describing that the patient woke up, I can't even explain what it is unless that the value is wrong.
Yes, ma'am. Yeah, even it was a surprise for me, but it somehow worked in that moment.
Right. Did you check with the lab glucose?
No, ma'am, we hadn't that time.
Okay.
Yeah.
But a high is not common. Low is common. So that's why we do from the earlobe or the arterial line in the ICU.
Okay, ma'am. Okay.
Madam,
Thank you
one
very much.
question is there in chat box, madam. Any food which causes hypoglycemia?
Okay. Any food that causes hypoglycemia? The lychee fruit, what I told you, that it was a very classical this thing which was described
Came in the
in
Lancet.
Bihar. Pardon?
It happened in Himachal.
Yeah.
There was an investigation.
Yes. Because it was misdiagnosed as an
Paper came in
encephalopathy.
Lancet.
That came in Lancet. That's the only fruit that I can think of. But any other fruit causing hypoglycemia, I would have suggested to any diabetic.
Lychee is the one.
Sir, blackberry, I think the Neredu, what we call definitely, sir. Because I have seen many patients.
Areca nut is another one which can cause hypoglycemia.
Oh, areca nut. Okay.
Yes.
This we have seen, sir, in our practice regularly.
The violet colored one you're talking about?
Yeah.
Oh, okay. The one that makes the tongue all violet.
Yeah.
Oh, that one. Okay.
Sir, Tamil emantar, sir. Neredu pandini Tamil emantar, sir.
Nagaparam. We call it Nagaparam. Yeah. But I've eaten that a lot as a kid. I don't think I ever got hypoglycemic. We had a tree from the next house onto our terrace. And one of the favorite summer holidays occupation was climbing the tree. So I don't know. I never got hypoglycemia, but I'm not sure. Maybe you have seen.
Sir, Swami, sir. Aladi Mohan, sir, you want to comment or something, sir?
No, I think it's an excellent overview, and it has covered all the major aspects. It's a very illuminating talk for a physician. I thank Madam for sparing her time.
Presented in the form of clinical scenarios rather than theory. That's quite interesting, and I would like to appreciate that way of presentation.
Thank you.
That's very nice, madam.
Thank you.
Madam, if there are no other points of interest, what next, madam? Shall we call it
Sir,
a
up
day?
to you, sir.
Sir, right. So on this occasion, I congratulate madam for a very excellent talk, and all senior faculty members, in spite of their busy schedule, for joining and giving their valuable suggestions and interacting with the speaker. I thank all the people who have presented, and I thank Bashir and his team for their present background, helping at various stages. I thank one and all, and with this we will close, madam. Good night.
Thank you
Thank
all
you
for the
very much,
opportunity.
madam.
Thank you very much.
Thank you very much.
Excellent, excellent, madam. Thank you very much.
Thank you. Bye-bye.
Namaste.
Thank you, sir. Swami, sir. Can we leave, sir?
Thank you, madam.
Thank
Good night,
you.
madam.
Good night.
Good night.
Thank you,
Good night.
Bashir, for helping us and video technologies. Particularly, I want to thank all the heads of the department, sir, because with that WhatsApp group, I think the number has been increased. Last month, it was only 30. Now we have gone up to 55, ma'am. That was a very good number. So really it's a happy, still we have to see good attendance, ma'am. Thank you very much.
Thank you.
Thank you, madam. Namaste. Good day.
Namaste. Namaste.